Today is Wednesday, August 11th, 2021. Welcome to the 319th episode of COVID Calls, a daily discussion of the COVID-19 pandemic with a diverse collection of disaster experts. My name is Jacob STEERE-WILLIAMS. I'm a historian of public health at the College of Charleston in Charleston, South Carolina. This week, I'll be the guest host of COVID Calls, while the program's founder, Scott Knowles, takes a much-needed break. My focus in the history of public health is on the field of epidemiology, a science unfolding in real time during the COVID-19 pandemic. This week on COVID Calls, I'm speaking with some incredible scholars who in some way work in the fields of public health and epidemiology. If you missed yesterday's episode, I had a terrific conversation about epidemic identity politics surrounding HIV/AIDS, the origin of epidemiology, and pandemic archives with Dr. Jim Downs. Today, I'll be chatting with Dora Varga and Mandisa Mambali. Just a reminder, you can usually catch COVID Calls live weekdays at 5:30 p.m. Eastern Time. Today, we're streaming at 10 a.m. Eastern to accommodate the vast time differences between myself and my guests. To find the program, go to COVID Calls TV, YouTube TV channel. You can also hear COVID Calls anytime recorded as a podcast on Spotify, iTunes, Podbean, or anywhere else you get podcasts. You can keep up with COVID Calls via Twitter using the handle @COVIDCalls, myself @STEERE-WILLIAMS, or Scott @US of Disaster. Please help spread the word about COVID Calls, and feel free to send suggestions for guests and future topics to either myself or Scott. As of today, August 11th, 2021, there have been 4,318,058 deaths from COVID-19 worldwide, according to the Johns Hopkins University Coronavirus Resource Center. It's absolutely sobering to me to think that in the past 24 hours since I spoke with Jim, 9,675 people have died of COVID-19 worldwide. In the 2 days I've been guest host of COVID Calls, 19,042 people have died of COVID-19 worldwide. As a healthy person with currently a healthy family, my heart goes out to all those that have lost this immense amount of life in just 2 days. It really puts it into some perspective that I haven't thought about this entire pandemic. The JHU Resource Center reports today that there were 617,769 vaccine doses administered yesterday in the U.S., although that still only contributes to 51% of the U.S. population that has been vaccinated against COVID-19. As a way to humanize those numbers, I'll each day this week read a real-life story or a story of advocacy for those impacted by the pandemic in some way. That's something that Scott has been doing from the outset of COVID Calls, and to me, it's a powerful reminder of the ways that pandemics strike populations globally, but we experience them as individuals in our individual communities. My story today comes from Durban, South Africa, reported yesterday, August 10th, 2021. Sadness and grief overcome KZN town after 9-year-old schoolgirl dies of COVID-19. Durban, an outpouring of grief and sadness struck the KwaZulu-Natal town of Ladysmith after a 9-year-old schoolgirl succumbed to COVID-19. Shanika Balsarang, a grade 4 pupil at Asabal Primary, died August 1st, 3 days after she fell ill with COVID-19 symptoms. She was cremated on August 3rd. Scores of her fellow schoolmates and teachers lined up, some inconsolable with grief, outside the school as a hearse carrying her body made its way along for them to say their final goodbyes. The teary-eyed community released balloons into the air and threw flower petals at the funeral motorcade. According to the Ladysmith Herald, Shanika and her whole family had been infected by COVID-19. A teacher at the school told the publication that Shanika had been taking care of the family and then suddenly complained that she was not feeling well. She was the family's only child. She fell ill on the Friday and on Saturday had died of complications related to the virus. Suri Kathan, department head for foundation phase at the primary school, told the Ladysmith Herald that she taught Shanika from grade R and that the 9-year-old's death was a huge shock. Educators and learners here can tell that Shanika had a heart of gold, and she was one that would just make a person's day with her smile or her greeting. I don't think anyone here at this school did not know who Shanika was, she said. The primary school girl's death come as a number of COVID-19 cases in KwaZulu-Natal, driven by the Delta variant, continue to increase. According to the National Institute of Communicable Diseases, KZN was second behind the Western Cape in terms of new infections and accounted for 21% of all new cases reported on Monday. Countrywide, there were 241 more hospital admissions in the past 24 hours, with a total of 14,820 now in hospital with COVID-19. So my guest today, who I'm really thrilled to speak with, Dr. Mandisa Mambali joined the Department of Historical Studies in 2017 from Stellenbosch University. She's currently at the University of Cape Town, where she taught social anthropology. She obtained her doctoral degree in modern history at Oxford University. Her main research interest is in health policy and activism, considered historically as interrelated phenomenon, both transnationally and within South Africa. Dr. Mambali has explored this theme in book chapters and journal articles on AIDS activism and policies, health, gender, and sexuality, and the politics of race and ethics in international health. In 2013, she published her scholarly monograph, South African AIDS Activism and Global Health Politics with Palgrave, as part of their Global Ethics series. This monograph was completed during postdoctoral fellowships at Yale University and the University of KwaZulu-Natal. More recently, her work has analyzed transnational debates over apartheid and medical humanitarianism in late 20th century South Africa. She's also working towards developing a comparative historical approach to examining the global health politics of AIDS and COVID-19. My second guest is Dr. Dora Varga, who is professor of history and medical humanities at the University of Exeter in the UK. Dora's expertise is on the history of epidemics, the politics of health, and Cold War history. Dr. Varga's interests span from the politics of epidemic management to public health systems and access to therapeutics. Her book, Polio Across the Iron Curtain, Hungary's Cold War with an Epidemic, was published open access in 2018 with Cambridge University Press. She's also written on the global infrastructure of the diphtheria antitoxin, the politics of vaccination in Eastern Europe, hospital care of disabled children in communist context, and about shifting epidemic narratives and historical analysis. Dora is currently working on a couple of really interesting research projects. After the End of Disease, which pushes back on conventional narratives of epidemic bell curves, and Socialist Medicine, an alternative global health history. She is also co-editor of the journal Social History of Medicine. It is such an absolute pleasure to have both of you here with me today to talk about COVID-19, history, epidemics, activism. But I want to start with just where are you calling from and what is the pandemic situation there? I know we're all sort of experiencing this a little differently from around the world. So Dora, why don't we start with you? Tell us where you're calling from and what the situation is in your local community.
Hello, Jacob, and thank you so much for inviting me. I'm currently in Germany, in Berlin. I moved here a couple of months ago, so I have immediate and recent experience with the UK and Germany as well. I think right now the epidemic situation is about 35 to 40 per 100,000 in cases in Berlin. And the vaccination campaign is not going as fast as they're hoping because the vaccine uptake has slowed down. So just now I read in the news that they're planning to introduce a fee for COVID testing, which has been free for anyone who has lived here, because you need that to go to restaurants or enclosed spaces. So you can either prove that you're vaccinated or you have had COVID in the past 6 months, or you need a test from the past 24 hours. So the plan is, I guess, that if they make that testing no longer free, then that will be an incentive to get people to be vaccinated, so to make their own life easier. But there's a lot of debate about vaccine mandating through the back door, and a lot of uneasiness about that. And of course, the UK has been, a very different experience, and it has actually made my move quite complicated. I had to come through France because of the growing number of cases and the Delta variant. A lot of countries imposed very strict entry requirements from the UK. until recently. So it's been, it hasn't been that visible in Berlin, and you can go anywhere. So life is quite okay, especially compared to lockdown situations. But there is still mandatory mask wearing FFP2 masks. So it's not any kind of masks on public transport, and masks within any enclosed space. So that's kind of part of life.
How is compliance with mask wearing?
It's very high from what I've seen. So everybody has their masks on in their pockets and put it on, take it off. As even in the open air stations, everybody's wearing them, and children have to wear them in school. They get tested regularly in the beginning, so there's a lot of things that are very stable and haven't changed for a long time. So I think it's become part of people's behavior.
Yeah, that is such an interesting phenomenon, and especially for you being in the UK and now being in Germany, seeing that transition of similar epidemic context with the rise of Delta, but then seeing the response from everyday people and from local officials just being vastly different. I mean, what you're describing for Berlin sounds nothing like my everyday reality in Charleston in the US South, where, yes, there's vaccine hesitancy still. And, I think that's something that I want to talk about in all of our different contexts, because I think there's a lot of similarities happening right now in the world in whatever stage we might be happening to be in this pandemic. That vaccine hesitancy seems to be one common theme. But everyday people willingness to accept really basic, simple precautionary measures like wearing masks indoors is something that is wildly different and controversial throughout the world right now. So I'm interested to jump in a lot of those questions, especially since you considering your research on the history of polio and children, which, in the phase of the pandemic that we're in right now, that seems to be of big concern regarding new epidemiological data on the incidence and the virulence of COVID-19 and Delta Plus and Lambda in children who are unable to be vaccinated. So a lot to talk about. Mandisa, let's bring you in. Tell us where you're calling from and what the pandemic situation is there. I mean, there's so much to talk about with what's happening with COVID in South Africa right now.
Yeah, I mean, just in the middle of a terrible third wave. There were a very high number of cases in Gauteng, where Johannesburg is situated, which is our main economic hub. And that's starting to abate a lot more. But where I am in Cape Town, the Western Cape, unfortunately, the case level is still very high, the death level is still very high. And it's pretty sobering what's going on. So I went to online a funeral of someone who's close to me last week. And the really terrifying thing was to see the hearses lined up, to see the other undertakers and families literally queuing up to do further burials. And it's extremely serious. But there's something else I wanted to mention, Jacob, which is this situation with COVID, and thank you for sharing some of the stats earlier on, comes on top of our HIV/AIDS epidemic, which is still ongoing, right? I was looking at, again, over some numbers today, and what you can find, if you look at it, is there's 200,000 new HIV, there were 200,000 new HIV infections in 2019, and 74,000 AIDS deaths in a calendar year. And that's roughly the same as the 74,000 COVID deaths over a longer period. So what I'm trying to do here is blow up the myth that HIV has ended, the crisis is over. That is not true where we are, unfortunately. So this comes on top of, a great burden of other infectious diseases. And, in an African context, you can't necessarily say that the stereotype of, oh, well, infectious diseases were placed under control in the late 20th century, with the exception of AIDS. And then suddenly there was this, epidemiological transition over then to chronic illnesses. Because what's happened in an African context is, A, infectious diseases never subsided. And B, we've now got, chronic diseases on top of that. So unfortunately, a number of people who are passing away from COVID also have type 2 diabetes, for example. So we're sitting on multiple, overlapping crises.
Yeah. And add to that, I was in the Western Cape in 2019 when I saw you last, and to think about what's even happened in South Africa from 2019 until now, with thinking about ecological disasters and water crises and political crises that are happening in the last 6 weeks, and I think like all of these are coming together to produce real crisis and real trauma in real time. So it is, absolutely, as you say, sobering. And I think one of the things that you bring up here that I know I'm really fascinated by and want to hear what you both have to say too is, if you look back to throughout the last, let's just say 100 years in the history of public health and epidemics, it's never been as easy and tidy as what I think a lot of people in the public discourse think, that like the 2 or 3 leading causes of death are the 2 or 3 things that we tackle. It's never been a kind of one-to-one relationship in any way that's that straightforward or easy. And I think, Mandisa, you make that really clear and in some of those shocking numbers of HIV/AIDS, of saying like, here's an ongoing disease crisis that is in some ways very hidden. I think that we certainly have seen that happen in the US as well. I was talking to Jim Downs yesterday about that very same phenomenon. And if you open it up globally, it becomes even more prescient. I think the way that in the politics of global health, it's never as simple as like, here are the leading causes of death, and here's where we're going to funnel resources and funnel money. And I wonder if what either one of you have to say about that. Dora, you want to jump in?
Yeah, thanks. And I was just thinking, Mandisa, that I think you and I should talk a bit more after this, because these are exactly the kind of things I've been really interested in, is how these the funds and the priorities shift without actually almost divorced from what's going on the ground, because of the kinds of narratives we're telling, because of the kinds of ways we imagine epidemics that that are causing issues somewhere but not other places. And what are the key places? Of course, entrenching these inequalities and global inequalities, and also the kind of comorbidities that these diseases are producing. So I think that is an extremely crucial issue of that, when the attention to an epidemic ends. And this is something that I'm kind of fearing with COVID as well, that there will be pockets where it will be devastating, and there will be also plenty of people who will be just they're left to their own devices, or just kind of unseen or not talked about or unaddressed, because the kind of the narrative has moved on, or the attention has moved on.
Yeah, absolutely. And I think like in the global history of public health, what you see is so many diseases that, Western public health officials by the mid 20th century, they start to champion and say that they've conquered, right? They become intractable diseases of the global South. And that's something that I think, we as historians and scholars of public health recognize and we teach, but I don't feel that there is a big global consensus on that kind of phenomenon. Mandisa?
In terms of, as I've written elsewhere, in terms of the whole end of AIDS kind of narrative, first of all, I was thinking about it this morning, and often there's a focus on sort of what I would term so-called celebrity activism. So I was thinking about, Live Aid, historically, and then now Vax Live, and kind of how the narrative gets taken over, in terms of focusing on particular individuals versus what I think can make change happen, which is community-based mobilization that is really targeted around the particular social characteristics of a community, and that is made by people, developed by people themselves in a community autonomously, So it should be empowering. So something I'm concerned about is we talk about things like so-called lockdowns. They're public health restrictions to save lives. We don't need that military kind of rhetoric. We talk about quarantine. Is it not about sort of responsible management of travel? Instead of talking about, okay, so our communities decide what their priorities are and have locally tailored solutions. And I was reading something in Washington Post yesterday about a very successful Spanish language community-based intervention to encourage vaccination among a predominantly Latinx area in Maryland. And that made me think back to the Treatment Action Campaign in South Africa and how they did HIV positive people themselves spoke to doctors, developed their own awareness materials, shared their own experiences of being on ARVs. And that was a time where, a bit like Donald Trump's pseudoscience, our president, Thabo Mbeki, was spouting things about HIV not causing AIDS, ARVs being poison. So in actual fact, with what happened with Donald Trump, I actually saw interesting parallels,
Wow.
you know, with our situation in South Africa historically.
Yeah, I'm completely fascinated by that, you know, as a current phenomenon of how we in our local communities are dealing with COVID-19, particularly with vaccine hesitancy and with local government, you know, public health measures. And I want to throw something out to see if either one of you are seeing this in your community. There's no doubt that in the history of public health in the last 100, 150 years, that community activism at the local level has made really important strides in curbing epidemics and endemic chronic diseases and creating awareness and real positive change. And here's what I'm seeing in the southern US. I'm seeing that where that activism is right now is from right-wing conservatives who are going to school board meetings, speaking loudly about not wanting mask mandates, not wanting lockdowns, not wanting any kind of COVID protection, not wanting vaccines. They're spreading myths. They're being extremely active. And I don't see, at least in my communities, in the U.S. South, I don't see that kind of activism from a public health perspective happening in local communities. Dora, you want to weigh in there? Is there any parallels you're seeing?
I think it's partly. That's a very good question. Of course, one of the answers is that the right is, and especially the far right is very organized. So it's hard to keep up with that kind of organization and very on point. Simple, messaging that others might see as a much more complicated issue, and therefore that kind of communication and strategy might not work like that. But just not even on the level of community, what I've seen, and this has been something that I've been discussing with one of my colleagues, Jessica Reinisch, who's in the UK, of the different way that also states or governments are engaging with communities and or representing society as a community. So you can see that it was striking for me coming from the UK, as there was in the UK, it was more about kind of a little bit of a guilt inducing communication, and in Germany, it's all about all the communication, every poster you see reminding you that you would want, you need to wear the mask, is that we're doing this for each other to keep each other safe, and that is that there is that kind of collaboration encoded into the communication. Of course, there is significant vaccine hesitancy, because obviously not everybody's buying into that, and this is what is weirdly bringing together the far right and the far left. It's a weird expression, but people on the left who are very much against, very suspicious about big companies and certain kind of like business interventions and globalization. And so these two very opposing political forces are kind of, protesting together. So it's also a way of bringing together these distant communities. So I think it's also, useful to think about what the community is that is engaging and breaking down society into communities where a lot of the meaningful action can be taken, but also thinking about community as a bigger and, ideally as a global community, which is also what is definitely not happening. And I think national is right now where it stops, which is a huge problem, obviously.
It is, yeah, and I want to talk more today, and maybe now is a good time about that very phenomenon. As historians and scholars of pandemics and epidemics and of disease and public health, we recognize that, and I think there's widespread recognition at some cognitive level that we're dealing with a pandemic that doesn't know geopolitical boundaries, right? And yet, a lot of our reporting, a lot of our everyday awareness of COVID-19 is about our local communities. I mean, I'm even seeing, in the U.S. South in the last 18 months that it's been, the reporting is hyper local. Even it's not even national; it's hyper local, let alone global. And a real lack of awareness about real global trends and what's happening with COVID-19. Mandisa, what's the situation like in South Africa, either about activism, local awareness, global awareness about COVID-19? I mean, one of the things that strikes me about the situation in South Africa is just, between environmental disasters and between political problems and instability right now, that often those, I think, create disaster situations that make COVID-19, I might imagine, a very local phenomenon, even though we know it's a global phenomenon.
Well, one thing I wanted to say, which is an old idea that I've been discussing a lot with colleagues and students, is the whole concept of social medicine. I think it's time for us to dust that concept off, developed by Rudolf Virchow in 19th century Germany. And it's an idea that anti-apartheid activists enthusiastically took up. So you meet people where they're at. Patients can drive things. Interventions can be local. The health of a patient is about the health of society, the water they drink, where they live, gender equality. All of these things start to come into play when you take a social medicine approach. And then, instead of doctors patronizing patients and communities and telling them what they need, communities should actually explain or discuss what their own priorities are. So in South Africa, for a lot of people, their worry is about their food security and groceries. A lot of women, their worry is about sort of endemic gender-based violence in this country. And also a lot of people feel that the state is indifferent to them or quite distant to them. So I was going over actually some of the latest studies on vaccine hesitancy. By the way, unfortunately, not enough of it, in my view, is qualitative. It's quantitative studies, and I'm not sure I can attest to the accuracy because there's such variation in percentages that one is, offered. But one that I was very interested in talked about how when the participants were surveyed, depending on their demographic features, they talked about different things that would persuade them to get a vaccine. So, for example, in rural areas, a number of people who are poorer, for example, Black Africans said they'd be quite willing to listen to traditional healers or traditional leaders, whereas more affluent people in urban areas often have more internet access, listen more to social media. That applies in particular, according to the one study, to white Afrikaans-speaking people who are also much more amenable to listening to their community policing forums. And then in terms of urban Black Africans, ones who were African National Congress supporting were more likely to listen to their ward councillors. So remember, UNAIDS said, know your epidemic. It has to go down to that granular level with, organizing around the vaccine. But just one quick thing about global health politics, right, is a lot of people aren't even fully aware of what the WHO does. So the full definition of the right to health, the full definition of health is a state of complete, social if I may, etc., well-being, and not merely the absence of disease or infirmity, which means that social medicine and human rights-based approach is officially baked in to international law and has been for a long time. But international law, as I've argued elsewhere, as regards the right to access to healthcare, there's no enforcement mechanism around economic, social, and cultural rights. So even though COVID has killed so many people so quickly, international health agreements, it's taken ages. Even now, the TRIPS waiver thing with the World Trade Organization, I'm not holding my breath for that to be resolved anytime soon. So, and then it's like the points of leverage, because the WHO, people forget or aren't aware of the fact that all it's empowered to do is to offer scientific advice to governments. As we saw in China, governments have to then invite them in. They're dependent on data that governments make available to them. We saw this also with SARS. We also saw how the initial global AIDS response was weak, was underfunded. So to address it at a global level, we have to go back to the nuts and bolts of looking at global health governance. And I'm afraid I was going recently, once again, through David Fidler's work on SARS, where he talks about SARS having instituted a post-Westphalian approach to global health governance, i.e. that now it was supranational modes of responding to a public health emergency. And I'm afraid to say, I don't see that in relation to this particular pandemic. I see nationalism, I see xenophobia, I see vaccine nationalism. And I don't really know what to say about finding a global solution, but we need to also dust off the history of AIDS, that, the global health, the global fund for AIDS, TB and malaria, why isn't there equal funding for COVAX now? A lot of things that happen and what also maybe we need more a specialized agency for COVID, because I'm also worried that there's other work WHO has to do, for example, on AIDS or on polio, for example. And COVID can't displace every single other epidemic infectious disease just because it's kind of more of an equal opportunities disease that is airborne compared to other epidemic infectious diseases that are kind of concentrated, among the poor and marginalized. So I'm worried also that in the global health agenda in general, are the other diseases going to become neglected because they affect the bottom billion of humanity, like the poor and marginalized.
Yeah. And there's so much to unpack there. Thank you so much for that, Mandisa. That really incredible view on global health politics right now. And I think what we're seeing is a pattern that I suspect is familiar to the three of us, right? And it's because there have been from at least the mid 19th century public health officials and epidemiologists who have said we need to take a global public health approach. And we need to understand pandemics as defying geopolitical boundaries. And yet there still hasn't ever been a real consensus either about what a real global health in terms of real time that you're talking about, Mandisa, real time policies, what that would actually look like. And instead, there's been people hand waving and screaming that we need a kind of global public health. And yet it is reverted to hyper nationalism time and time again. I want to actually, as a way to try to unpack this, go back a little bit into a couple concrete historical examples. And the one I want to start with is Dora, your work on polio. So in June of 2020, you wrote an essay with Jeremy Green of Johns Hopkins called "How Epidemics End" in the Boston Review. And I love this piece so much. I assigned it in both my classes last year, and it's one of the best that historians have written. And in that essay, you and Jeremy argue that so many of our hopes in ending COVID-19, and you're writing in June of 2020, were in the promise of a vaccine. but you argue, and I'm quoting, a closer look at one of the central vaccine success stories of the 20th century shows that technological solutions rarely offer resolution to pandemics on their own. And that's June of 2020. And here we are in this very prophetic way reading that essay. And I read it again the other day in August of 2021, when vaccines are widely available in some parts of the world, although, of course, not all parts of the world. And if you look at vaccine access right now, it is widely disproportionate. But if you even take the US and Western Europe and parts of the world where vaccines are widely available, and we still see this hesitancy, take us back to the story of polio, which I think is one that in the mid 20th century that we can use to really understand a lot of the same forces that are working in our world right now in this, maybe, what people are calling the third or the fourth or wherever we're at in this wave of the COVID-19 pandemic.
Yeah, I've been thinking a lot about that, of course, as the pandemic was unfolding, and it kind of had echoes of a lot of things that I spent a lot of time studying and thinking about. And there were several things that I, thinking and looking at historical precedents of vaccination in a situation where you have the common problem all over the world. And that was, of course, different in the number of deaths. It was different in how it manifested everywhere, but it had that kind of really strong power of afflicting children and making very visible, long-lasting sign, like leaving long-lasting signs. So that was, propelling a lot of collaboration. And just to, throw a little bit of positive stuff into this really gloom and doom, because that's what it is. It did create collaboration between opposing political sides. So there is kind of a hope, and the WHO was instrumental in as a vehicle of where people could work together that would otherwise wouldn't have been possible. So I think there is definitely a strong role to be had for international organizations that, of course, have changed drastically since then and have been gutted in a lot of ways. But what happens, there were 2 vaccines developed. And of course, I knew that even if we take into account of a very optimistic way of thinking about the history of technology, of how now everything's so much better and smart, even on a progressive, narrative, it took years. It took many years, decades, for vaccination to actually, take hold and do that kind of work. So you have the first polio vaccine coming out in 1955. And partly it was a question of access. So there was a huge lack of vaccines. There was political game playing of how you can get it, especially if you don't have the funds for it, especially if you're on the other side of a huge, Cold War. And even if everything worked out, there were some instances where the vaccine just didn't work on a social level. So this happened in Hungary. There was a huge epidemic wave. They vaccinated, they used the vaccine apparently in very high coverage, and it didn't work. And so I started looking at, what goes on into these vaccinations, and how we can think about vaccines and vaccination. And it really shows that complexity of the the logistics and the infrastructure and the society and the relationship between the state and the people who are receiving the vaccine, the knowledge that is circulating, the doubts that are circulating, the specific methods, the different kind of vaccines that are competing. And you have a second vaccine coming in the late 1950s that is, for various reasons that I will not go into because it will take a lot of time, is finished in a collaboration between the Soviet Union and the US. So this is the kind of collaboration that makes possible, tested in the Soviet Union, and that creates a lot of doubts. And we can see that immediately, like a knee-jerk reaction to when all these different vaccines appeared. Which one are we going to trust? Which one are we believing? Like, are we taking for granted that these figures are to be trusted? These figures are not, but based on exactly what, yeah. Right? And people, in the case of Hungary, where people could choose which vaccine they got, and which COVID vaccine they got, pushing away certain vaccines and demanding others, even if that means that they will be vulnerable for a longer time. They cannot get vaccinated for a longer time. But going back to the late 50s and 60s, you have this new vaccine that is easier to administer, and it's there are arguments that it works better. It's a way to really put a stop to epidemics. In Hungary, it gets very quickly embraced because you have this situation in a very volatile political environment, and it pairs partly, and this is, I'd like to come back to Mandisa's point about social medicine and a different way of thinking about society and health, where the basis of how to roll out vaccine and the success of vaccination is inseparable from horizontal structures there, with Red Cross volunteers knocking on people's doors and talking to them, with the community health centers everywhere that are coordinating this, and the whole population has to get vaccinated in a matter of days, right? So, and they do that, and that's kind of the whole infrastructure is needed for that. Eastern Europe becomes, gets into quite a good place in terms of polio sooner than other parts of the world, partly because of the ease with which these vaccines flow. And then the vaccines get this political meaning. This is a success of the political ideology. This is the success of the whole political system. And of course, if you follow the routes that the vaccine takes, you can map these socialist networks. Cuba becomes the first country in the Western Hemisphere to be polio-free through this collaboration. An interesting thing is that as the vaccine travels, and it kind of changes political meanings. In Brazil, you have these national immunization days that are all based on Cuban data that was developed with Czechoslovak and Soviet virologists and vaccines, but it falls to the wayside until you get to the Polio Eradication Initiative, which is a philanthrocapitalist enterprise. And this is where it's kind of coming from, and the methods and the models. So there is a lot of interesting and important, interesting things going on with that kind of intertwining of the politics and vaccination. But this is decades, right? We're talking about decades, and it's not only vaccine hesitancy, and it's not only the availability of the vaccine. It's hundreds of other little things, from the conversation between the physician and the parent or the vaccinee, to are these syringes faulty, or where do we get can we keep it cold? How does it get from A to B? Who's organizing it, and so on and so. So there's so many things going into it that just the technology itself, it doesn't do anything. The substance in a vial, that's not where the boundary of this technology is. It's everything. Yeah. And so when I was, of course, thrilled and very excited that and very impressed that this has happened so quickly and so fast. And it's quite unprecedented, I think, this kind of rollout and response to an epidemic. But knowing that this, in the best case scenario, is we're talking years and decades, and it will bring up even more and new problems, just like as Mandisa was highlighting with HIV and the COVID and the comorbidities and the overlaps of chronic and epidemic. And so even if it kind of ends, that is also a kind of very problematic ending.
No, that is so incredible. Thanks. Thank you so much. And one of the things about reading your book that really struck me is just how this narrative happens in Hungary about a success story of polio, and in like that happens in the US too, right? That there's we and our scientists, and then you put Jonas Salk on a pedestal and you say like this was American ingenuity that solved the polio problem in the US. And to put that into perspective, and the way in which like these heroic narratives of overcoming a disease, they get entrenched in national questions of national identity, are something that like I keep waiting for that to happen in the US with COVID-19. I think it eventually will. We will start to get some of those narratives emerging, those heroic narratives about COVID. But I think from this history that you've unpacked for us with polio, I think, one of the real things that historians can offer right now is this like very prescient reminder that like we're just getting stuck in with COVID-19. I mean, we are dealing still with immediate trauma and really difficult numbers of daily deaths that are hard to process. They're hard for individuals to look around and to see, here's my tiny little place in the world, and then know and humanize those big gigantic numbers of deaths, those daily deaths. And I think what you highlight in the story of polio is like we need voices from historians of pandemics and people that have studied this to try to help us to, one, humanize those numbers, but two, to realize that like the story of COVID-19 is not the story of 2020 or 2021. It's going to be a story that continues for a very long time. And it's going to be a story that changes over time. It's not just, as we know that the virus itself isn't stable, it's an always changing, adapting entity. The pandemic itself continues to change and continues to morph. And that's something that I think like the polio example and like the promise of the technology and then the heroic narrative that we put on the technology, it doesn't play out when you actually look at the history, right? And that's something that your book is so brilliant at showing. But I think like what it also reminds me of, and Mandisa, I want to pull you in here, is the way in which like the story of HIV AIDS is in some really powerful ways, maybe the other prescient story for how we might understand where COVID-19 might go in the next decade. So I want you to like maybe help us to think through like HIV AIDS is this amazing story, and in particularly globally, but especially in South Africa, of a disease of visibility and invisibility as that disease was recognized and then continued, and as you mentioned earlier in the program, continues in strikingly high numbers today, yet is in some ways very invisible.
Well, I think one of the lessons for me is, again, with social medicine, it's sort of fashions in global health. Yeah. So sometimes treated like it's kind of this old-fashioned, stuffy kind of thing. But there's something else quite boring, which ties in with what Dora was saying, which is health systems strengthening. So one of the lessons from HIV/AIDS is we now have tremendous combination ARV therapy, but drugs don't work in people who can't take them, and medication has to be prescribed by doctors and nurses. And if there aren't enough doctors and nurses, or if the doctors and nurses are too far away, or if the clinic and the pharmacy is underfunded, the patients who need, that medication will not get it. But I think there's another lesson, which is also like I was alluding to earlier. We need more biosimilar versions of the COVID vaccines and more production in the global south. Hence the issue of patent waivers comes up. But I think, to be honest with you, sometimes I think about it, I feel like as humankind, we're kind of on a merry-go-round, There's this pandemic, that pandemic, a global health governance architecture that is not fit for purpose, no focus on actually in general improving health equity and health systems in the global south. Also, a lack of joined-up thinking. So, given the reality of zoonosis, we need to have a sustainable development or one planet kind of approach to thinking about global health. by one planet, I'm alluding obviously to the interconnection between animal and ecological health and human health. We can't think about them as separate things, right? So I think what I'm trying to say is that we need more permanent fixes. But here, with health systems strengthening, it's not that a lot of people haven't thought of it or that it hasn't been pushed by many different interests over the years. It boils down to what I would like to call medical capital. So all the private health insurers who rake in massive administrative fees, and then who often in South Africa or in the US work in tandem with specialists or hospital groups that also, work for the private sector, who then inflate the costs, who also then, there's obviously the multinational pharmaceutical companies who inflate the costs of the medicines because they often are secretive about the price of drug development, and what is overlooked is the amount of federal US tax dollars invested in basic scientific research to develop new medicines. So I feel like, we actually have to think about the social institutions globally that are blocking health systems strengthening.
Yeah.
And I think the problem is also we can't pit different diseases against each other. This has been being said for a long time in global health circles. So then if you have a systematic way of looking at all of these infectious diseases, then we can look at institutional changes to rules, budgets, timelines, and and then be ready for the next one. Because do we really want to go through this again? I think, time has come. And because AIDS became like a poor part of the world disease, this has gone on the back burner for far too long. Whereas I think now I'm hoping there might finally be political will, but I doubt it, because I think medical capital is extremely powerful and enduring, particularly, since the rise of the Washington Consensus. So, I don't know.
Yeah. There's so much there. Thank you so much for all that. I think you're completely spot on, and I wish you were in some position of real political power. But I mean, but that highlights a couple points to me. One is like, where do we as scholars of public health fit into this? Because I think like you've identified in the last 2 minutes some of the central problems of global health, and like, what do we do as scholars? I think there's real questions about how we can be and are activists in our local communities, in our universities, in our cities, in our nations. What kind of role can we play as scholars who have studied this extensively, and where might we find that voice? That's one question. And two is like, there's an old-fashioned narrative in the history of public health that I think in many ways has been like super, I don't want to say debunked, but like contextualized and complicated. Like Charles Rosenberg long ago argued that like epidemics were these moments when they forced change on society. A big epidemic happens. Cholera strikes America in the 19th century in successive waves. And then people respond, and then they implement things as a direct result of the epidemic experience because of the trauma of epidemics. And I don't know, Mandisa, from what you're saying, like you're presenting a much more grimmer view of that. Like maybe epidemics aren't these galvanizing forces of social change. I think they have the potential to be. I think we look around our world today and we're seeing with COVID-19 a major kind of reckoning about how communities govern themselves. What is the social contract? I mean, living in a city without and starting a university term without mask mandates and vaccine requirements, and sending my kids into public schools where other kids won't be masked and their parents probably won't be vaccinated. I feel like we have totally failed the social contract of just like caring about other human beings at a really basic level of humanity. At the local level, let alone at a very big global level where we've seen like, I talk to students in my history of disease and public health class always about cholera. And I refused for the story in the history of cholera just to be one of like, well, it was in successive waves in the 19th century, but then it was over. because it wasn't over. It became an intractable disease in the global South. And that's the story of cholera, because it's a real story. And you know, there's the story of HIV/AIDS that you've worked so much on, Mandisa. I think is another like really prescient lesson for us. But I wonder if either one of you have either thoughts on like what we can do as scholar activists to try to push back against these narratives, where we fit into our communities, and then this other big question of like, at the end of the day, what do epidemics really do to our communities? Dora, do you want to weigh in on either one of those questions or statements?
Yeah, well, first of all, I think, you know, just going back to that point that you made about epidemics being a vehicle of change or not, I think I think more about epidemics as being kind of accelerators of, if there's underlying problems and inequalities, it will make them bigger and graver. If there's already some kind of change going on or something that is already happening, it might amplify it because it gives a moment where that then, you know, can step up. But I think in itself, it doesn't do anything as any crisis. It just strengthens what's already there, either in the divisions and the inequalities, but also in, if there are already existing, you know, something collaborations or something, some social movement going on, then that can give it a boost. But as you know, as historians and academics, I've been thinking a lot about this lately, because I have been engaging. There is a growing interest from global health practitioners, from healthcare practitioners, about how to think about this and think about it in a bit more thorough and critical way, not just being in the moment. And I think partly, especially in history, I think partly that comes from that early part of the pandemic when everything was so new and everything was so uncertain and there was no information, right? And how does it spread? How do you treat it? What do we do? What is the efficient way of dealing with this as a society, as a government, as a person, you know, in a family? And so without any kind of hook, you know, people started looking back, you know, maybe some past pandemic or epidemic will reveal answers. And that kind of, I think that is a change that happened, that there is a kind of openness to history, which often, you know, in a popular level translates to the lessons learned of history and or you know, interesting tidbits. But I think that the key question that I think we can do is to show that we can provide an analysis, an in-depth analysis of something that we cannot do in real time, because there's no time. It's moving on. It's you know, we just have to like kind of survive and deal with it, and it's moving way too quickly. But you know, we have the luxury of time looking back, and we can really explore it. And it's all because it's so complicated and it's so complex, and there's so many actors and so many things going on at the same time. Yeah. And then, you know, you can use that to ask questions and to help people ask questions, and to serve as entry points for analysis of what you can look at. How does something become invisible? What kind of people are we not considering? What kind of people, you know, where does this potentially can go, right? Who gets forgotten? How do these meanings of disease change? And these are important. And I think there is, I think at least that's what I found as a coping mechanism, I guess, because there is a sense of helplessness in this, and you want to kind of do something, and it's hard to do something if you're not medically trained, especially, and you can't actually just go and try to heal people. And I would say that even in COVID, you know, that's also a frustrating experience because you oftentimes can't. But so kind of to do something is to open up these new ways of thinking and show that also that the situation that you know, Mandisa so eloquently described has this historical trajectories. We need to understand how we got from there. Where did these social medicine, you know, ideas go, and why? And what are the ideas that we've forgotten about? What are the practices that have fallen out of favor, or they were politically inconvenient at the time, and so on and so forth? And then, you know, think in a nutshell, that's kind of where I see that kind of activism go.
Yeah. Thank you. Mandisa, where do you see, I mean, so much of your own research focuses on health activism, but I wonder, like, where do you see as, like, what is our role as health activists, as scholars that study this exact phenomenon in moments of crisis like this?
That's a really important question. I want to build on what Dora was saying, in that I'm writing something at the moment where I'm starting to think about, a hazard of sounding a little cliched, the idea of the end of the beginning of the COVID pandemic rather than the beginning of the end. So I think in a way now, because there is an effective biomedical intervention which can substantially prevent transmission, or, most importantly, prevent hospitalization or death, that then gives, to some extent, physicians, ourselves, scientists, breathing space to actually think about longer term social, cultural and political interventions. But the problem is, so there's some physicians who are friends of mine, and they were actually talking about the concept of an interwave. So basically the period between two waves sort of thing. And so even for them, like, the kind of work that I would like to see, long-term ethnographic, oral history research, also documenting the work they have done in a systematic kind of way, is time consuming. And also ideally you have to be able to do it face to face. So there's a whole research agenda I can think of, and a lot of other colleagues, that we simply may not be able to implement, unfortunately, unless there is a substantial, durable reduction in transmission, hospitalization and death. So, I mean, one of the things that I've been trying to do is public outreach. So I gave a radio interview the other day, and I'm going to be giving a couple of other talks. I mean, my colleagues who work on Spanish flu have been really run off their feet, and now Dora, because she looks at vaccination. Yeah. So as we go through different periods, and now I'm quite busy because of 40 years of AIDS.
Yep.
So, at different points, kind of different historians of medicine are busier than others. But I think us working together with policymakers, physicians and so on, it will come, but it will take time. Because like I said, I think that, the flames are still being fanned, as it were. So I don't know. But Dora, I really like what you were saying about science diplomacy. I think we need more of that, where different, scientists from different great powers come together to, and other middle-income countries, for example, come together to develop more scientific solutions. But I don't, Jacob, want to sound like a massive pessimist. I think the TRIPS waiver is really important. I think there are local examples of successful efforts, like the one that I mentioned to you. And so we shouldn't give up. But the things that we're pushing back against are long-standing institutional, society-wide issues, and are just purely the innovation of a vaccine in and of itself is not going to fix those things, although it's tremendous medical breakthrough.
Yeah, absolutely. Yeah, I mean, I think, like, one of the things that you both highlight is, like, it's so easy, especially, and I want to say especially as scholars who study pandemics, and epidemic and disease and public health, to be super pessimistic right now. It just really is. It's almost like, I open up Twitter and it's just like Twitter COVID rage every single day. And it almost feels like a vacuum. And I actually have been trying to put that, my own experience into a little bit of perspective here, because I think, like, at once, I think there's, the daily death counts and the daily hospitalization rates, which are going up right now. And this new question about Delta Plus and new variants evolving and their susceptibility to unvaccinated children are really serious and grim questions that I think, like, we want and we need real like answers from the specialists on those questions, right? But I think at the same time, like you're right, Mandisa, that like we also need to recognize like what can we do as individuals in our local communities to make positive change. And I think that's really important because, I mean, I look around in just in the US, to give that example, and there are some states whose vaccination compliance is over 60%, 65%. There are other states that vaccination rates are low 30%. Like we need to be looking at communities that are doing well right now around the world, of vaccine rollout, vaccine hesitancy, of community activism, and try to draw on that as examples for us to influence our own community, because we are in a moment where, yes, the pandemic continues to change and evolve and adapt, and still kill people every single day and rip apart families in devastating ways. But we also, I think, can play roles in our communities that are really positive ones. And I think every example of past pandemics in public health shows that too. And I think like it is really important that like we can be that voice as scholars of pandemics too. Not just the grim always warning signs. So I think like there's some real like checking of my own like privilege as a historian of public health that's weighing heavily on me right now personally. And maybe we need to have more discussions amongst historians of public health and activists too. So I cannot thank both of you enough for joining me today on COVID Calls. This discussion has been completely mind-blowing to me, and like in some ways like really therapeutic, honestly, to talk with two amazing experts. So thank you both so much. And I hope that at some point as COVID Calls continues, that you come back again to talk with Scott, because there's so much more to talk about from each of your areas of expertise. Please join me in thanking Dr. Dora Varga and Dr. Mandisa Mambali. Please check out their work, follow them, follow their research, follow their voices, their important voices, and join me tomorrow on COVID Calls when I will speak with Dr. Lakshmi Krishnan and Dr. Lorenzo Cerviche, and we'll talk more about medical humanities, public health, and the state of the pandemic tomorrow at 5:30 p.m. Eastern Time. Thank you.
Thank you.